Good evening, ladies and gentlemen, and dear colleagues. I am Jubail Islam, Secretary of Bangladesh Medical Physics Society. I wish all of my colleagues around the world a happy International Medical Physics Week 2023. I am pleased to welcome you to our first webinar session of BMPS on the occasion of International Medical Physics Week. You will be glad to hear that already 330 participants registered from this for this webinar session, around 40 countries. And today's program will be conducted by Dr. Anwarul Islam. He is a coordinator medical physicist, Esquire Hospital, and also immediate past president of Bangladesh Medical Physics Society. Now, I would like to request Dr. Anwarul Islam to conduct this session. And now is your floor.
Thank you, Secretary Anwarul Islam. Okay. Ladies and gentlemen, esteemed colleagues and participants of the International Medical Physics, it is my honor and privilege to welcome you all as the session moderator of this today's event. As you know that the International Medical Physics is a global platform that brings together medical physicists and professionals from around the world to share knowledge, exchange ideas, learn from each other experience in the field of medical physics. As a session moderator, I am excited to guide and facilitate our discussion during this event, ensuring that we have a productive and engaging experience. We have an exciting lineup of sessions throughout this week, covering the wide range of topics in the medical physics. I encourage all of you to actively participate, ask questions, and engage in meaningful discussion during the sessions. Let's take the advantage of this opportunity to learn from each other, build connection, and advance the field of medical physics together. Once again, I welcome to all of you to the International Medical Physics Week. Let's make this event memorable and enriching an experience. Today's topic is the role of medical physics in the international role of medical physicists in radiation protection, and it is conducted by Dr. Pradip. Pradip is an academic in medical radiation research supervisor and radiation safety officer in the School of Health and Biomedical Sciences at RMIT University in India. He obtained BSc Honors and MSc in Physics from University of Chittagong, Bangladesh, and MA-PhD in Medical Physics from Queensland University of Technology, and PhD in Nuclear Physics from University of Melbourne, Australia. He was a Melbourne University Research Scholarship recipient, Australian Institute of Physics Gold Medalist finalist, International Media Star of RMIT University. Prior to RMIT University, he worked in the University of Melbourne, the Ohio State University, and the University of Tasmania. His research interest includes nuclear model, radiation dosimetry, radiation safety and protection, and physics education. He has supervised 10 PhD students and authored more than 100 papers, 2 research books, and 30 popular science books. And this is all this about Dr. Pradip Dev. Now I would request Dr. Pradip Dev to conduct the session. Thank you.
Thank you very much. So can I share my screen now? All right, so let me share my screen with you. And I hope you can see my screen with the title on it.
Yes.
Yes.
Okay. Right. So I think I'll start now. Good evening and Eid Mubarak to everyone. And thank you very much for inviting me in this webinar series to celebrate the International Medical Physics Week 2023. And I'm feeling very honored to talk to you in this evening. My talk, or what I will be discussing with you, is about the role of medical physicists in radiation protection. So the role of medical physicist is very wide, and also who are the medical physicists? That is also very wide. We get different types of definitions from different area of the world, and from different organizations actually define medical physics and medical physicists differently. Just to see one, say, International Organization of Medical Physics that defines the medical physicist as such like this. So the medical physicist apply knowledge and methodology of science of physics to all aspects of medicine to conduct research, develop or improve theories and address problems related to diagnosis, treatment, and rehabilitation of human disease. They are directly involved with patients and people with disabilities. So basically, the medical physicist, as it says, the International Organization of Medical Physics, saying or claiming that they are directly involved with the patients and the people with disabilities to help their life and to get their diagnosis, proper diagnosis, and the treatment. Although that is correct, but many patients, almost 90% of the patients, they don't know who the medical physicists are, what are their role in their treatment process, because they don't see, the patients don't see medical physicists in action. So is this definition wrong? This is not wrong, but as a medical physicist or the medical physicist community are not very kind of familiar with the patients yet. So there is another definition, like the medical physicist, they are actually the medical physicists are those who do medical physics. So what is medical physics? To many people, medical physics is a new branch, but we know that the medical physics is not very new. Basically, medical physics is very deep-rooted in physics. So medical physics is a branch of applied physics that is definition by Australian College of Physicists and the physical scientists and engineers in working in medicine. So that is our medical physics organization in Australia. So their definition about medical physics is, it is a branch of applied physics which employs physical concepts for the prevention, diagnosis, and treatment of human disease. So it is a truly diverse field that utilizes the knowledge gained in other areas of physics and applies it to heal people. So that is again saying it's directly related or involved with the treatment of people or treatment of patient. So that is again saying the main branches of that physics that work. So medical physics has 4 main specialist area, we all know around the globe. First one is the radiation oncology that deals with the treatment of cancer patients through radiation therapy. So in that radiation oncology, basically it developed the treatment plan. To do the treatment plan, it do the imaging and also the validation of treatment plan. The second one is the nuclear medicine. So we know that nuclear medicine involved with radioisotope treatment and also diagnosis. So all these gamma cameras, PET, SPECT, all other very sophisticated imaging modalities and the treatment modalities are in terms of nuclear medicine. So these are full of actually run by medical physicists. So behind the workforce is the medical physicist. Radiology, that's involved with the diagnosis by using X-rays, CTs, ultrasounds, MRI, etc. So all sorts of the imaging modalities are in terms of radiology. And the fourth one is the radiation safety. But the fourth one, the radiation safety, is actually involved the all other specialized areas. So in radiation oncology, radiation safety is very important for patients because the patients of radiotherapy patients, they are getting huge amount of radiation. So every single patient dose needed to be controlled and validated by the medical physicist. So nuclear medicine involves with radioisotopes where the patient become radioactive. So the patient management, radiation dose management is very important in nuclear medicine, and that is done by medical physicists. And also another thing in nuclear medicine is very important, that is like the management of the radioactive waste. So radioactive waste means when we have got radioisotope, that is also managed by medical physicists in nuclear medicine. And also the say patient, when patient become radioactive in nuclear medicine treatment, the patients, anything patient do, suppose the patient urinate, that urine of the patient is also radioactive. So we need to have a better, good plan for managing those radioactive waste. Otherwise, it will actually contaminate the environment. Also, it can be dangerous to other people. And radiology, it's basically the radiation dose to the patient is coming, most of the dose coming from the CTS and etc. So medical physicist has got a huge role to play here in all sorts of radiation protection in all branches in the medical physics. Now, I have looked at the Bangladesh Medical Physics Association website, and I'm very happy to see that the definition about medical physicists there are actually very well written, and it's cover almost everything that what we do. So medical physicists are healthcare professionals with a specialized training in the medical application of physics. Their work often involves the use of X-rays, ultrasound, magnetic and electric fields, that's MRI we're talking about, and then infrared and ultraviolet light, that is like the non-ionizing radiations, and also heat and lasers in diagnosis and therapy. It actually covers everything what we say, but it is actually not clearly saying about the radioisotopes or nuclear medicine, especially like a kind of separate way. And most medical physicists work in hospital diagnostic imaging departments, cancer treatment facilities, and hospital-based research establishment and in universities. So it is very important that medical physicists do lots of research for the betterment of treatment, for the betterment of diagnostic imaging, and also for the betterment of the management of the whole medical physics environment. So that means the research is done mostly by medical physicists. So you see that medical physicist has got a huge role, and also the radiation protection principles are established by the medical physicist. So why these are so important? Because we're saying that medical physics, when did medical physics started? We can say that medical physics started from the discovery of X-rays. But even centuries ago, all this medicine that like the diagnostic tool in medicine, like say thermometer, stethoscope, pressure meter, everything are based on physics. It's the physics properties are applied, and then like say a thermometer is just the heat properties, and that is physics. And stethoscope, that's sound properties, that's physics. A pressure meter, that is the pressure of physics, so that's applied there. So there are lots of equipment that used in medicine that are contributed by the physics, but still we are not saying a different field of medical physics were born, but we're saying the medical physics started from the discovery of X-rays, or we can say as the moment the X-rays were discovered, the medical physics were born. So you can see that here, this is the first, the discovery of the Röntgen. So the Röntgen, like this is the first X-rays that made by Röntgen of his wife. And it took about like 15 minutes. And like she was very scared of, she said, I have seen my death. So that means from the beginning of medical physics, there were some kind of like a kind of scary things came, because radiation cannot be seen, radiation cannot be touched, radiation cannot be tested. It doesn't, we cannot even see it, we can't feel it, but it is there. So it is a kind of like using something that you cannot see, you cannot feel, you cannot touch. So it is very difficult to use. But at the beginning, people did not know that it can do harm. So what happens is, right after X-rays were born, the whole other things were born. So we are saying that the medical physics, a lot of people say that medical physics is a bit new branch, but it's not the new branch. It's very deep rooted, because when the medical physics were born by X-rays, right after that, a lot of new branches, new discoveries are done in physics. A completely new physics, or physics took a new turn for the whole century. Like say, right after the year of X-rays, we have got radioactivity by Henri Becquerel in France in 1896. Then we have got Curie's, and Pierre Curie and Marie Curie, they discovered radium and polonium. So we have got radioactive materials. Before that, we did not have any idea what radioactivity was. So then we have got a new idea of that. So that means we have got the X-rays are being used right after that. So one thing we need to remember, that when X-rays were produced, next year, 1896, we have got radioactivity. So that radioactivity is a completely new thing for our physics community. And then right after that, by using the X-ray properties and etc., we have got a separate, that means, or we can say, very basic fundamental particle, that electrons were separated. Electron charges were measured. Electron mass were measured in 1897. So we are saying that electrons were discovered in 1897, right after X-rays. So, and within few years, we have got, say, like we got our Rutherford gave us the proton and nucleus, and then whole nuclear physics were established, nuclear physics were born, and then by 1911 to 1913, we already got the atomic theory. So Bohr atom theory, atom model is there. So that means we are developing the whole atomic structures and so on. And by 1932, we have got the nucleus. So you see that by the born of medical physics, the whole development of physics started. So we cannot just say that physics is a new area, medical physics is a new area. It is a very old area and deep-rooted physics, but we did not apply that one in that way. So who first started the medical physics? Who were the first person in medical physics? Who was the first medical physicist? Well, it is very difficult to answer who was the first medical physicist, because when people already knew that X-rays can do a tremendous work in the diagnosis, they just started X-ray by using in different establishment. But Marie Curie was the first one who used in the larger scale the X-ray. We call them a kind of mobile X-ray unit. So if you look at here, this was the little cars. So Marie Curie used this little car with the mobile X-ray unit. She established about hundreds of these little cars. Those little cars were called Little Curies, along with her daughter. Her daughter was only a teenager at that time, Irene Curie. So they used X-rays in a mass scale to treat and to diagnose the wounded soldiers in First World War. So that's why we all know that the birthday of Marie Curie is celebrated as the World Medical Physics Day. So now from there, a continuous development were done in the medical area where medical equipment, say X-rays were earlier stage was like this. You see that people were just using by hand, and also like a X-ray plate that is a kind of say film where like hold by the patient himself here, and then no protection. You can see no protection here at that time because people did not know the harmful effect of radiation. So you see that here, the X-ray tube is completely on. The patients are having an X-ray, and that so close to the chest of the patient. And also here you can see that this X-ray tube is completely without any radiation protection, radiation shielding, and the people are just standing there. So this, everyone is getting radiation, the same amount of radiation what the patients are getting. So that was an area at that time, and people did not know. But from then we have like moved about 100 years. We are getting like lots of new and modern equipments. But remember, we haven't actually got any change in the production of X-rays, but only we use the control of it is now is computerized, but inside the X-ray tube is still the same way of X-ray production. So this was one of the earlier version of CT machine, and now you have got the modern CT machines, but we have got huge development in the CT, but the dose also increased at that time. So this is one of the gamma camera, modern gamma camera we have, radiotherapy machine, the gamma knife. So there are so many different types of the machines we are using now. So what happens is the frequency of diagnostic imaging, like the numbers of diagnosis imaging are increased day by day. So here we can see that from 1988 to 2008, and also now we haven't got the unscared data yet for the recent years. So you can see per 1,000 population, almost 500 per year is getting some kind of diagnostic imaging. So that means half of the population of the world having at least one diagnostic imaging per year. So that means we are using radiation tremendously. It's a continuously increasing. And if you look at the average dose per person, annual effective dose by only diagnostic imaging are increasing. So radiation protection is very important there. We cannot avoid radiation, but radiation protection is important. Like say medical, most of the background radiation we are getting every year, it's coming from the medical radiations. So, and some terrestrial, some radon, some cosmic, some our almost inside our body. So radiations are there, but how harmful are they? Why radiation protection is important? Well, first evidence we have got is, say, we can say that the first, like the carcinogenesis, we say radiation can cause the cancer. Marie Curie and Irene Curie, we can see here they're at work, radiation tube are there. So they were exposed to radiation of X-rays and also radioactive material for a long time. And both of them actually died of leukemia. So we can say that they discovered radioactivity, they worked with radioactivity, but they died of them. And also we have got some other evidence that developing cancer is directly happening from radiation, excessive exposure of radiation. Here is the hand of a dentist who worked for 35 years. We know that dentistry, the X-ray radiation is not very high, but it is a continuous X-ray to the hand because the hand was actually like holding the plate, the small film for the dental X-rays. And there were a development of tumor here, and then the thumb has to be partially amputated, and then damaged skin for the fingers have been replaced by grafts and so on. Basically, it's a kind of cancer development. So for the earlier version of all sorts of radiation, we have got evidence that the radiation can cause cancer. Radiation can actually do harm to human. But how much dose is dangerous? So radiation risk estimation is a continuous process done by different the radiation protection societies, and those are led by medical physicists. So medical physicists are inherent, they are doing their inherent role everywhere. So like say below 0.001 millisievert or 1 microsievert, we cannot see any evidence of human health effect. But up to about like say 1.7 millisieverts, that is in Australia background radiation, we can say. And even if we have got a 20-hour flight, sometimes we get about 100 microsievert dose. But chest X-ray, it's just only 20 microsievert dose. That is like a very low. Dental X-ray is even lower than that. But above 10 millisieverts, we get like 10 millisieverts dose from CT scan, and that is a plausible health effect. So even if you start from a CT scan of the abdomen, it's about 10 millisievert. So we can get like 50 millisievert dose from the national emergency reference level, and also an astronaut, like if they are in the space for about 4 months, they can get about 100 millisieverts. So these are plausible health effects. We are not sure about it, but there is a possibility of having cancer or some other DNA damages. But in the radiation therapy, we use about a sievert dose or more than a sievert dose, the 100 millisievert, 1,000 millisieverts are doses, and etc. So if this dose we use in radiotherapy for killing the tumor. So you want to eradicate the whole tumor off. So that is our aim in radiation therapy. But if we miss the target, what will happen? So we are giving radiation, our targeting to the tumor. Tumor will be destroyed. But if you miss that tumor for a few millimeters, it will destroy all the normal cell, normal tissues will be gone. So that will be too dangerous for the patient. And also that can cause the secondary tumor or secondary cancer for the patient. So medical physicist has got a huge role here to play, that the controlling the dose and to actually targeting the dose. So that comes with the planning. So effective radiation doses, we can see that these are very small dose from like the CT head, this about 2.2 millisieverts. But if we have got a CT abdomen, it can give us about 7.5 millisievert. That is a high dose. It's a plausible problem with the patient. And also sometimes for say thallium-201 can give us about like say nuclear medicine can give about like 20 millisievert dose. So that is a huge dose for one nuclear medicine work. So what are the risks there? So we already know from the International Commission for Radiation Protection has based on data collected all over the globe, we have got about like the effective dose of 1 sievert will have an additional lifetime risk of radiation-induced cancer of 1 in 20,000. What does that mean? So medical physicists here needed to be explained this one to the general public. Otherwise, if you're saying this one to the general press, they will make it a sensation saying, okay, it will give you cancer directly. But we saying that the risk will be increased 1 in 20,000 people. So that means if 20,000 people getting 1 millisievert, 1 sievert dose, it will increase. Not everyone will have got the cancer because the cancer risk is not the deterministic effect. Deterministic effect means if you're giving the same amount of dose to everyone, everyone will have got the same effect. But the cancer is not the deterministic effect. So, and also CT head will increase the dose, increase the risk, and also thallium-201, that's the cardiac nuclear medicine, that also can increase the risk. So how do you read that risk? Normally, if a person do not have any radiation exposure, the risk is about 1 in 4. And cancer is a kind of like certainty for our older age. Like in Australia, the people live more than 80 years. So when the people live more than 80 years, their chance of having cancer because of old age is about 1 in 3 or 1 in 2 in some cases. So radiation has got an influence there, but radiation is not the sole responsible for the risk of cancer. But now, no matter what are happening, what are the risks there, the number of CT procedures are increasing. So as you can see here, USA has got like the highest number of CT per 1,000, and also like the Germany, Canada, and Japan has got the second highest. But Australia is not very high compared to like 1,000 population. Only less than 100 is getting a CT procedures. Why? Because in Australia, the radiation protection rules are very, very strong. It is not allowing anyone to just prescribe a CT instead of X-rays if it is not justified. So that is very important for us. In many countries around the globe, the people, like where the regulation is not very strong, there are multiple CTs are done unnecessarily. So the patients are getting huge amount of radiation, and that radiation can cause cancer, can cause other DNA damage, tissue damage, and etc. And it can have long-term effect. So that regulation needed to be done, and medical physicists can have a role there. So we have already seen several papers. This is once published in Lancet saying that radiation exposure from CT scans in childhood and subsequent risk of leukemia and brain tumors can actually increase. So this paper actually says the brain tumor or the probability of leukemia can be twofold and threefold if a pediatric patient or a child having a CT in their early age. So how can we prevent it? This information needed to be justified, needed to be explained, and the perception of this one needed to be like explained scientifically, and medical physicists can do that. So there are concerns about the appropriateness of some imaging. We always complain, especially in the developing countries, we always complain that the physicians are giving unnecessary tests. We are always saying thousands of dollars are being paid just for unnecessary tests. If you visit a physician, they will give you X-rays, CTs, whatever they feel like. And general public always complain that they are actually getting a percentage from the vendors, they are getting a percentage from the clinics and etc. But medical physicists can get a role there. So they can not individually can do, but collectively medical societies can actually just get a voice here. So about 20 to 50% of the diagnostic imaging fails to provide information. That means they are unnecessary or redundant. So you see that these are from the developed countries. Even these are done, or saying this study are done in US, and even in the US there are like more than 50% of the diagnostic imaging are saying unnecessary. And also suggesting that about 2% of cancers in the US may be attributable from radiation from CT scans. So these large cohort of studies were not done on CT in Australia, but we cannot say every diagnostic imaging are not necessary, but certainly some of the CTs are not necessary. So the rules needed to be providing a very strong regulation saying that if you can do something with ultrasonography, you should not go for X-rays. If you can do something with X-rays, you should not go for CT. So that is the voice can be raised with logic by medical physicists. So like in the New York Times, they actually just headlining this one, we are giving ourselves cancer. Why? Because we are doing lots of CT unnecessary. So there are correctness on also sometimes the press makes sensation with some pseudoscience there. So medical physics community has to explain it to the general public. So we know that there are some direct evidence of radiation incidents. So I'll show you a few images here. Some images are not very like a kind of a good image, but these are basically direct images coming from the consequences of excessive radiation. So this is a very famous one because this is because of the excessive interventional radiography. A huge fluoroscopy image were done here. So that skin is damaged. And as you see, this skin is permanently damaged. So this is excessive radiation caused that, and there is no healing process of this one. So skin grafting was the only treatment for this one. So there are like the radiation burn. So radiation burn are evident. So you can see that this person hand was exposed to the excessive radiation, and by 3 weeks it was not shown anything because radiation burn come from the inside. So inside it damaged the DNAs, and then when it comes to the surface, the whole skin is damaged. As you see here, the whole skin is damaged completely. This is another patient who has got huge amount of radiation on the abdomen because of the interventional procedures needed to be done, and this skin was completely damaged. So this is the plastic surgery needed to be done here to actually cover this one. Otherwise, there is no treatment. This will not be healed automatically. So that's another, like the more dangerous thing happens in radiation therapy if the dose is not monitored properly by the medical physicist. So this is sometimes the accident happen, and that accident normally cannot be just initially cannot be seen what happens. In one of the radiotherapy machine, after a kind of power shutdown, a very small diode in the circuit was lost. So when the medical physicists checked they couldn't find it. So they delivered the dose to 3 patients, and these 3 patients got huge amount of radiation that was not seen at the time of delivery. So what happens is the first patient got huge amount of radiation, and second one also, and third one also. So the damage was permanent. So this second patient has got the surgical scar, and then it was not healed even after 6 months of time. And the third patient was even more, dose was about 25 gray instead of like a kind of 8 gray dose. So these are done by the treatment. So the patient went there for the radiotherapy treatment, but because of the accident or like a kind of malfunction of the machine, they got this one. It cannot be undone. There is no way we can say that it will be undone. No way. So the consequences, who is responsible for this? Somewhat the treatment authorities are responsible for this one. So you have to be more careful about radiation delivery. So from the beginning, as we know, like that there are harmful effect of radiation. If you look at this time scale from 1900, when we just started our medical application of radiation, after 1925, we had no limit, almost like we say 2,500 millisieverts or 25 sievert. That was like huge. Then we realized that these doses are too high. So this came to about 500 millisieverts. So 1940s, it came to 250 millisieverts, and 1960 to 1900, roughly about 85, it came to 50 millisieverts. Now, from the middle of 1980 to 1990, about 1985, the whole world has taken a kind of stand unitedly. They're saying our occupational radiation dose should be not more than 20 millisieverts per year. But one country in the world, they still using 50 millisieverts per year, that is the USA. So why they're saying that? Because they're saying their excuse is, they're saying it's too much paperwork, but nobody is getting up to this 50 millisieverts, so we don't need to change. But the rest of the country, everywhere, they have got 20 millisieverts for the occupation, and for the general public, that is 1 millisieverts. From where we get this? Because the world know that radiation needed to be like kind of protected. So radiation protection is very important. So you have got international committees, so International Commission for Radiation Protection, IAEA, Unscared, World Health Organization. These are international body. They have a kind of influence of all countries, but they normally advise. So I can discuss about the Australian one. So you have got the ARPANSA. So ARPANSA is the Australian Radiation Protection and Nuclear Safety Agency. So that is the government agency that look after the radiation protection. So they form the radiation protection. They have high power to check radiation protection. So they establish the radiation protection principle. They basically promote the safe and effective use of ionizing radiation in medicine, ensure the risk, and enhance the engagement, and also enhance the organizational innovation capability and resilience. So behind these, all these factors, medical physicists are there with their logic and with their calculation and with their science. So they deliver expertise, they deliver advice, they deliver regulation, they deliver best practice and services, and more importantly, the research. So this field needed continuous research. So any country, the medical physics body, they are researching with their own country data and then matching with the international data, because the local data are very, very important to establish international best practice. Medical radiation physicists can actually do that thing best. So in Australia, we have got very strong regulation about Radiation Act. We call it Radiation Act. It has got a very strange and very strong power. And that power gives us the radiation safety. Main aim of this Radiation Act is to radiation safety, to protect the people from the harmful effect of radiation. So how do they do it? They basically do three basic radiation protection principles. Justification. That means if a procedure is not justified, so that means we know that radiation has got some harm, but it has to have more good than bad. If there are more bad than good, no way you can do it. So that's the justification. Then limitation, dose needed to be limited. So that means if you can do something by 1 millisievert, you should not give 1.1 millisievert. So that's the rule. And the third one is called the optimization. It's the protection and safety. So that means as low as reasonably achievable. That's very, very important. So that means what we can do as low as possible. That's the optimization. So optimization process, so justification, limitation, and optimization process needed to be applied. If any of this is not applied, that is against the law. So radiation management plan needed to be done for any radiation facility for treatment or diagnosis purpose, need to have a radiation management plan. These radiation management plan are managed by radiation medical physicist. So the radiation management plan include everything, especially the radiation for pregnant women and also radiation for the women of reproductive age, because we know that radiation is very harmful for their offsprings. So that needed to be managed. And also the protection of individuals, the carer who actually take care of the patient, that also needed to be like kind of protected. And also there are specific instructions for tailoring the procedures of patient size and the clinical needed, and also the amount of radiation that needed to be given to the patient has got there. So we have got from these in the world, we have got an annual effective dose limit for the patient and for the worker as well. So in Australia, we allow 20 millisieverts per year on the average of over 5-year period of time for the radiation worker who age is more than 18. So there are some worker can work from the 16 to 18. Nobody is aged below 16 is allowed to work in radiation field. General public, their radiation dose should be limited to 1 millisievert per year. So in no way any radiation facility can give to general public more than 1 millisieverts per year. So how do you manage it? We have got licensing system. So this licensing system is very, very strict rule. And the licensing, without any license, nobody can do their business. A safety culture needed to be established. So these are governed by the government, but the authority, that's the advising authority, are medical physicists. So still there are things happen. So these are two examples that radiotherapy patients, but they have got side effect of this one. And this is because of the excessive radiation to the normal tissues. Another person, this should not be happening, but that happened. So, but who is responsible for that? This is because of the typical radiation incident. Why this thing happened? It can be wrong patient, it can be wrong quantity of radiation, it can be wrong organ of the radiation given, or miscalculation of the radiations. So why is this thing happening? This thing happening because radiation physicists, medical physicists actually did not do their job properly. So how it needed to be prevented. We need to analyze what are the reasons of this. It can be 4 different reasons. It can be human error. Most of the time, it is like kind of communication error, unskilled technologists. It can be a patient factor. Patient is not like, suppose patient is not kind of like cooperating. And also the technology factors. Suppose our machine is not quality controlled properly, or IT failures, or some other equipment breakdown that was not checked properly. And the organization factors. This is more important because the quality controls needed to be monitored, human performance, work overload, lack of professional development. These are all organization factors. So these can be governed by, once the radiation medical physicists are there, they can actually give the advice to the organization, or they can report it. Now, there are good law everywhere. We know very well that in our home country, there are law, very good law. The best rules are there in book, but people, when they don't follow the regulation, what to do? Well, in Australia, especially in Victoria State, we have got a very severe punishment system. So we have got serious offenses under the Radiation Act, and the punishment is very severe. The people can lose their license, and also the monetary fines. Give you an example. So we have seen some images where the radiation dose was very high, the patient has got the significant problem. And if that kind of thing happens, the individual can be penalized by 600 penalty units. So one penalty unit cost about $184 this year. So that would cost more than $100,000 for a personal fine. So if a radiotherapist done that, radiotherapist has to give a penalty of more than $100,000. And the institute need to get fined about more than $500,000 just because of the high radiation dose given. So if a person is conduct a radiation practice without a license, a proper license, or an kind of expired license, they had to give about $300,000 penalty in the personal level, and the institution level can give more than $1.5 million fine, and then they will lose their business and everything. So that is very severe, and no tolerance is there. So if that was not, then another one I wanted to show you, that is here, this is also very severe if a facility is abandoning some radiation source. Like say, okay, we throw somewhere or we don't care. If that thing happen, then can cause a severe effect. Why? We know that in Guinea, in the Brazil, say some facility, they abandon cesium-137 source when they just close their business. So it was just thrown it here, that did not mind. So some the thief actually saw that, they had no idea that that was radioactive. So they basically just spread it and wanted to sell it here and there. So it was spread there for about a few days, and then 4 people died, and then 112,000 people needed to be monitored, and it was severe. You can see the consequences of people who were actually came near to that radioisotope sources. So that is a huge effect to the general public. So you see that it was really, really a huge problem. So it went to about contamination of more than 1 kilometer and so on. So a simple misregistration or mismanagement can cause huge problem to the general public. So we need to be checking that. So a medical physics or a team of medical physicists can actually explain this one to the authority, and then to make them do everything right. So another thing is also very important. Sometimes people have no knowledge or very lack of knowledge. So the people who are working in the clinic, it's not necessary they know all the physics they need to know. Suppose nurses do the work, but very often they don't know what radiation is. And sometimes the doctors, they don't know what radiation is. So they are working in the emergency department. They don't know how dangerous the X-rays can be. We have done some research with our staff here, like the nursing staff here in the clinic in Australia, and we have found that more than 50% have no the sufficient knowledge. So in that case, it was a problem. So the training the trainers is very important, and that can be done by medical physicists. So in conclusion, we can say that few things. The medical physicist can play the most important role in radiation protection with their expertise in the subject. They can lead the radiation management plan and the quality control program. That means dose monitoring, radiotherapy treatment plan validation, radioactive waste management advice, and etc. They have responsibility to train the trainers through academic and professional programs. So the professional programs are run by the experts of medical radiation or the medical physicist. And also the professional societies, they have responsibilities to advise the authorities and be part of the radiation protection authorities. They are the authority, so they can manage the department very well when they know. And also they have got another responsibility, that is the improving the public knowledge and awareness. If public is not with us, we cannot get the best goal we are looking for. So with that, thank you very much.
Thank you, Dr. Pradip, for your nice and excellent presentation regarding radiation pollution possibility. So we have find some question in the same box. Unfortunately, I have to reason it, and I forget. I have missed some question. So Mr. Zuba sent me some question in my WhatsApp. I am reading it here. One question came from Abdullah Shahida. His question is, how can artificial intelligence enhance the treatment and diagnostic procedure and reduce the non-desired radiation doses?
All right, so this is a very timely question about the artificial intelligence. So AI will have in future, and also like we can say at present, AI is actually using a kind of having a very a good role, especially in the diagnosis where detection in the image. So that is very important role is actually played by artificial intelligence. And also another thing, it will come in future, near future, especially we are hoping that when the robots are taking care of radioisotopes, so that means the medical physicist or the staff will not get excessive dose, and also the human error can be eliminated by artificial intelligence, because like we can say the dose delivery will be done whole robotic, that's like the kind of the computerized. So that is we calling the artificial intelligence. And also another thing that will be a kind of very good application in this area of medicine is actually the data analysis. There are hundreds of papers are published every day. So it is not possible to track all this, but if we have got a kind of like the softwares that will be checking the dose, and it will have a kind of universal dose monitoring system where we can say the best international practice. So there are lots of avenues for artificial intelligence. But one thing, we cannot eliminate medical physicists, because artificial intelligence has to have the proper algorithm. So that's proper algorithm continuously needed to be developed, and the quality control of artificial intelligence needed to be done by the medical physicist. So it is a kind of tool, but we'll be using. It's not like they will not govern us. We need to govern them.
Thank you, Dr. Pradip, for excellent explanation. Another question: if radiation worker receive more than 5 millisievert in a quarter reading, what should we need to do him from the aspect of radiation protection? If someone get more than 5 millisievert.
Okay, so what happens is radiation, like the for occupational radiation dose, normally it has got like we have got the personal dosimeter. So personal dosimeter can be two ways. One, like say it can be direct reading, that is like electronic one that can be monitored every day, that can be real-time monitoring. And another can be a passive, like most of our vessel or TLDs, those are passive. So we wear the TLDs for say 1 quarter, for 3 months. So, and you see that, okay, dose is 5 millisievert. So still I have got like 20 millisieverts to be, like another 15 millisieverts to be acquired. So I have got 9 months in hand. If you can anticipate that your workload can give you about 20 millisieverts per year, so that should not be taken actually any action if it is 5 millisievert, because the regulation says you can go, like say if some particular year, it can go up to 50 millisieverts. Suppose, for an example, if there is a radiation incident happen in one of the meltdown of radiation, say a nuclear power plant or something, or some excessive radiation spill in the nuclear medicine department. So staff needed to go there to manage it. So in one particular year, it can go up to 50 millisieverts. So that's fine, but it is actually averaged in 5 consecutive years. So if some year I get 50 millisieverts, so next 4 years, I should not get more than 50 millisieverts. So that means in that case, my dose needed to be monitored or needed to be controlled that way. But there is just, if it is not a question, but I am just adding another scenario here that is very important for all of us to know, especially the scenario changes with our female staff members. So if a female staff member become pregnant during her work, she does not need to go home, but her dose limit is 20 millisievert per year. But as soon as she becomes pregnant, the unborn baby, the baby's dose is not 20 millisievert. Baby's dose should be monitored, should be kept less than 1 millisievert per year. So the person who is carrying the baby, her dose cannot be more than 1 millisievert per year. So what to do? Her workload needed to be managed by the authority, by regulation, because authority cannot say, okay, you take your maternity leave now. No, she can work as long as she wants, but authority needs to give her work in a way that her radiation dose will not exceed 1 millisievert per year. But that needed to be monitored every month. She has to have 2 TLDs or 2 dose monitors at that time, and that needed to be scanned every month, not 3 monthly, every month, because every month she has to check her baby's dose should not exceed 0.1 millisievert. So that is the responsibility of the authority. If she claims that, okay, or declares that I am pregnant, so from that day, her workload should be adjusted in a way that she can go to like non-ionizing radiation work or the desk work and etc. So that is very important.
This is a good, excellent topic, because every center have this situation may happen. So another question we get from, what is the radiation regulation for air hostess or pilot, as they are considered radiation worker according to ICRP 103? Why no personal monitoring device is provided?
Well, they have got their dose actually monitored by using, because you see that they don't need to have a separate radiation dose monitor, because what happens is everyone in the flight, including the passengers, including the pilot, everyone has got the same amount of radiation for the flight. Okay, but the crew members are frequently flying. So what happens is, in the cockpit, they have got dose monitor. So that dose monitors is actually monitoring the dose. So that dose is actually distributed by the hour they are flying. So their dose are calculated that way. They have got the regulation too. If their dose is, when their dose is more than 20 millisieverts per year, they have to have like a kind of like their work distribution should be that way. So their dose is not actually exceeding 20 millisieverts per year. And also, we can give you another example, but like the people who are working in the radiation mine, say uranium mine. So their regulation is like that. They also cannot have more than 20 millisieverts per year, but just not to get excessive exposure continuously, we are using a kind of, we call like the fractionation method. Same fractionation policy is used for the crews. air crews needed to have fractionation. They cannot continue fly for a month. They have to have like weekly off days. So when they do off days, that is their fractionation. They are not continuously flying. So same thing happening in the uranium mine. The people who are mining, if they are working, say 2 weeks in a mine, they will come back and they stay outside the mine or stay home for another 2 weeks. So this is the fractionation applied. So in that case, their dose is monitored and also not very acute dose to their DNAs. So what happens is, if we do fractionation, we know that if some DNAs are damaged, they can actually just kind of repair themselves. So that is actually less damage. So damage is a kind of like a fractionated.
Thank you. This is also very interesting. Another question is how gamma knife and gamma camera are used? Are they components of CT scan and SPECT scan, or used independently in hospital?
Okay, so gamma camera is basically like gamma camera is a nuclear instrument, we can say. So gamma camera is basically using for imaging. So that imaging is like, say, patient become radioactive by using most of the gamma sources. We use, say, technetium-99m. So technetium-99m is given to the patient. So the patient are given that technetium inside their body by injection. So patient will emit gamma. So gamma camera has got, say, it can be 2 head, 3 heads. So the head has got the detector. So that detector will detect gamma particles that coming from the patient, and then they'll produce the image. In the other hand, the gamma knife is completely different. Now, gamma knife is the radiotherapy procedure. It's basically, it's given the through, say it's used for a single dose of very highly radioactive beam that is basically coming from a large amount of radiation from linear accelerators, so or some isotopes that giving directly to the patient, so to the tumor. So if it is especially used for the brain tumor and so on, so that is one very high dose, very precisely given to the position. So the positioning is very important in the gamma knife. So I think the question has got some other parts there. Can you repeat, please, what was the other 2 parts there?
Sure. The question was gamma knife and gamma camera are used, are their components of CT scan and SPECT scan, or used independently in hospital?
Oh yeah, they are independent actually, because the like CT is a diagnostic tool, and the CT is there are 2 types of CTs. One CT is used for actually localizing radiotherapy. We call them planning CT. Another CT is like general diagnostic CT. So they are independent. Now there are more sophisticated modalities that are coming. We are getting like MRI, like the LINAC, and also we are getting like the CT. CT LINAC is very common. We are getting like PET CT, PET MRI, and etc. So there are actually nuclear medicine facilities, so radioisotope is coming fused with the X-rays and etc. So those are sophisticated modalities are coming, but they are independent.
Thank you. Another question from Mahfuzur Rahman: how the percentage of scattered dose from IMRT or BMAT would be incorporated during shielding calculation? He also says IAEA uses IMRT factor, which has significant limitation in practice. That means
so these are actually just IMRT is a special modality for the radiation like therapy protocol. So basically for a clinic to clinic, they have got a guideline like how you do the planning for, and it depends on basically the tumor volume and also the treatment volume. So it depends on the planning. So once we get the image, the planning image for the patient, only then we apply. So this one has got a guideline. We need to follow that guideline for, and different clinic will have got the different guidelines, how much percentage or how much the dose volume distribution will be given. So this varies patient to patient.
Okay, thank you. Another questions came from Masood Rana, Khan Masood, regarding TLD. When we send them to regulatory for reading measurement after 3 months, then get it back from them, it took about 3 days without any TLD batch with us. As a regulatory does not allow to TLD per person. What is the regulation in Australia? How the workflow there?
All right, the Australian regulation, we actually walk away from TLDs, but TLDs is like the thermoluminescence, so it needed to be like the heated and so on. Now we actually moved towards the OSL, that's the optically stimulated one, that is like kind of more precise and also more sensitive. So, and it doesn't need to do heat, it's basically done by the intense laser. So our regulation is basically per person, we have got 2 sets of OSL. Say my OSL is done, finished, like the wearing date, the last date is today. So before I hand this one, the second set, a new set of OSL is with me, because I'm working every day with radiation. So I cannot have without OSL a single day. If I don't have an OSL, I cannot work. So I have to have actually 2 sets of OSL. So one set comes, a new blank one, my old one is gone for reading. So no matter how much it takes, it doesn't matter, my dose will come. And by the time my wearing one is just given to for reading, my other one is coming. So basically, if I have got 5 staff member, I need 10 OSL.
Another question came, Moklesur Mondo. Can pregnant woman undergo a CT scan?
Can you repeat that one, please?
Can pregnant woman undergo the CT scan?
This is Mokles. This is a very difficult decision to make. Like our regulation goes like this way. Okay, as a radiation safety officer, if this question comes to me, my suggestion will be like this. So the pregnant woman, what are the purpose? The first, we need to do justification. So justification, I'm not saying that cannot go away. If where is the field of view? Suppose we need to go for, say, a CT. If the CT is for something that is completely away from the abdominal side, so the radiation coming there will be very, 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 very small. Say for head CT. So if a pregnant woman going for a head CT, it should not make a big problem, but we need to make sure that there will be no radiation to the fetus. Okay, but so if it is not justified, it is not necessary, if it can be done by something without non-ionizing radiation, we will say, okay, go for MRI. So if it is required, go for MRI. MRI doesn't give any, like the ionizing radiation, it will not give any problem. So that's fine. Another scenario is like this. Suppose we have got real case. I'm giving you the real experience from here. A patient has got cancer. A patient has got cancer. It's a kind of cancer in the stomach. So, but patient is pregnant. So at the same time, patient is pregnant, but she has cancer in the stomach, so she has to go with her regular radiotherapy treatment. So what to do? If the going the beam there, the unborn baby will get some sorts of radiation that is in the way. So the planning, here comes the medical physicist who will do the planning. So the planning for the treatment needed to be done in a way. The beam orientation needed to be done in a way, especially use the IMRT, where you can actually design your beam to avoid the fetus as much as possible. But you need to save the patient, and also you need to actually make sure that the unborn baby is not getting harmed. So the justification is very important. And also one thing we need to remember, any fetus dose less than 10 millisievert will not make a problem. Only there are no deterministic effect, but there can be some stochastic effect. So that stochastic effect is the risk. We need to take that risk, because that risk is equivalent to radiation or not radiation. It will be the same. So that is, here is the skill of medical physicist needed to be shown.
Thank you. I think there is no questions is there. Our moderator or the host, Mr. Zubair, invite to this session. He give us some evaluation from me regarding this session, today's session. So, however, I think that there is today's topic was very interesting, and also participant took part in actively take part. So this is I thought that this is a very knowledge sharing topic today, knowledge sharing lecture today. So I request Mr. Zubair to conclude the session. If you have any invited to more session or conclude remarks, please continue.
Thank you, Anwar.
Thank you. Mr. Zubair, do you have any invitation for tomorrow or
Yes.
Okay.
Yes. Thank you, our speaker, Dr. Pradip Dev. This really very impactful session for all our medical physicists who are working in the radiotherapy department and working as a radiation control officer or radiation protection officer. And now I would like to request to our participant the fill up our evaluation form. Only who filled the registration evaluation form, and you only get your certificate. And another announce, our next webinar session will be started at 8 p.m. in Bangladesh time tomorrow. The topic is surface guided radiotherapy overview of implementation and experience. And tomorrow's speaker is Abdul Sattar Khalid from Qatar. And now I would like to request our all participants, please fill up your evaluation form. After this session, you can do it. I would like to thank our speaker and our moderator to conduct this session, and also our participant. I once again thanks everyone for making this program successful. Thank you.
Thank you, Jovaril. Thank you, everyone.
Thank you, and good night.
And good night. Good night.
Good night.
Good night.
Bye.